Thank you, Chair and Professor Boris Maljugan. Thank you for inviting us, and Dr. Jerome Bouvet for keeping Presbymania such a success. Now, one of these buttons will forward and presbyopic. This talk is an attempt to be very objective. Now, what is the true meaning of spectacle independence with multifocal IOLs? It's easy to examine the eye and vision, and it can be done quite objectively, but the patient's response can be highly subjective. And as you know, neuroadaptation is totally unpredictable. Although we fill out forms and we ask them questions, we are never 100% sure. Large variations are also found in individual expectations and satisfaction. So multifocal IOLs, what does it offer the patient? Listen to this. It replaces presbyopia with bilateral, subtle, monocular diplopia. That's what we give them. And we have to understand this. And you may say that sounds very bad, but it's not really so bad. But only some patients can tolerate it. That's why patient selection is so important. If I look at my practice, where I am rather conservative, I eliminate 90% of patients based on ophthalmology reasons. And then we go to the questionnaire, and then we end up doing about 8% of patients with multifocal lenses. Now, I know there are other doctors who do more, but there are other factors in South Africa which may have an influence which is not the same in South America, for instance. So if the patient can adapt to this bilateral monocular diplopia, we are very happy and we can say it's a success. We have different results, and I used two lenses comparing the two. The first was the Restore, and the next one was Lentis Plus from Oculentis. This is a picture of the Restore, you must all know it. And our study results, this is just a summary. 75% of patients were 100% spectacle independent, which is not bad. Those people are more or less happy. 88% patients were 90% spectacle independent. The refraction, 89%, had a good spherical equivalent, and 6% had a cylinder of more than -1 for various reasons. And no eyes lost best corrected vision. This is a picture of the Lentis. Sorry, this thing just progresses of its own. It has a personality. The Lentis Plus looks like this. And I want to make a few comments on the results. Meticulous care was taken with optimizing of the IOL master to determine the correct A constant. But nevertheless, we found more myopia with the autorefractor than with the Restore, in spite of good uncorrected distant vision. So sometimes the patient had good distant vision, but it was a myopic eye. Why did we find that? We thought that some of the IOLs came to rest. I'm innocent, honestly. Some of the IOLs came to rest higher in the back than others, and in these eyes we contemplated that the autorefractor saw the near segment of the lens and gave false myopic lesions. As time went by, a significant number of these patients became satisfied with the result. And there we have our results. We did 52 patients, 71% of them were 100% spectacle independent. Our distant vision, 0.8 or better, 86.5%. I highlight the 0.8 because I find that the patient with 0.8 vision is happy. And then some of them had mini monovision with 1.25 or less difference between the two eyes. 11 patients had this, improving the vision of both eyes simultaneously. Intermediate vision, 0.8 or better, 90% of patients were 0.8 or better, which is not too bad. Near vision, this was worse with the lensless lens, 0.8 or better, 62%, 0.7 or better, 88%, 0.7 is J2, and you can do most things with 0.7, so that's actually not a bad result. The summary then, 71% of patients, 100% spectacle independent, 77.9% spherical equivalent, which was quite good, 6% cylinder of more than minus 1.5, 1.25 for various reasons. We lost a bit more one-line visions here in this group than with the restore. Complications, refractive, myopia, we got more of myopia here, as I said, astigmatism, which is something we're working on, and then optical. 79% of patients can see halo, starburst, ghost image. 21% complain about capsular contraction. In 2 patients, the capsule contracted and moved the lens upwards, and that was causing a lot of symptoms. Reduced contrast sensitivity. These lenses give reduction in contrast sensitivity across the board. I will not believe that you can put a multifocal lens in the eye, split the images, get more than one image and then not lose contrast. It's just not technically possible. Poor neuroadaptation, 8 patients had poor neuroadaptation, of which 7 were female. And then we had dry eyes causing complaints and floaters causing complaints. So sometimes patients have good vision but they're not happy. Unhappy patients, this is a complication. 19% of the patients were unhappy. The male patients unhappy. The reason was a good reason, myopia plus astigmatism, or poor vision for near. Female patients, poor neuroadaptation in 5 patients, and dry eyes with perfect vision, 2 patients. Now look at the neuroadaptation. What is poor neuroadaptation? The patient cannot tolerate side effects of multifocal IOL in spite of good vision. And this was interesting, 8 patients, 7 women and 1 man. One in the middle was a man, and you can see that his vision, near vision in the green, is not so good, so he has a reason to complain. And the one on the left is a woman, the others are all women. She has a 0.5 near vision, which is also a reason to say, I'm not really happy with the lens. But the other 6 ladies had good results. You can look at those visions. It's 0.7 to 1.2, and they are not happy because of poor neuroadaptation. So spectacle independence versus happiness. Total spectacle independence, 71%. But not all of them are happy. And as I said, 4 women are not happy, although they are spectacle independent. Spectacle independence versus happiness. Now we have happiness as a first thing. Happy patients who will elect to have the surgery again, 81%. Happy but not spectacle independent. 9 patients are happy but not spectacle independent. 7 of them are men, 2 are women. And then not happy and not spectacle independent, you can understand that because they didn't get what they wanted, 6 patients. So the advantages of this lens for the ophthalmologist, successful patients are very satisfying for the doctor. They are good marketers. It's a high risk reward ratio than monofocal IOLs. We get a bit more fees for that. And it's cutting edge technology, which always has pros and cons. Disadvantages of multifocal IOLs for the ophthalmologist, 19% patients are unhappy. They did not get what they expected. Namely, totally comfortable spectacle independence, and they are dissatisfied with the doctor. It's always the doctor's fault, you must know that. More post-op visits for these patients, average 5.2 visits for 2 eyes compared to 3 visits for monofocal IOLs. More chair time. You talk to these people a lot more, and if you multiply the visits with the time, these patients consume 3 to 4 times more time as many minutes as patients with monofocal IOLs. And you lose a few optometric friends because they send you a patient and they never see him again. Doctor's expectations versus the patient's expectations. The patient always expects 100% for everything. The doctor knows what to expect. And sometimes the patient is happy and I'm not. So there are people who are easy to please. The best combination is an easygoing doctor as well as an easygoing patient. Doctor says, doesn't matter. If you have double vision at night and the lights approaching you are double, it means the lens is working. And that's an easygoing doctor. And some patients like it, they just tolerate it. The worst combination is a perfectionistic doctor with a perfectionistic patient because they're always trying to make it better, and that's not always a good idea. Room for improvement. Consider, in our case, we have considered horizontal placement of this lens due to prevent late superior decentration due to capsular contraction, because this happened in vertically placed lenses. I must look at my astigmatism. Now, biometry is a problem because we do the most modern thing and we don't always get the result we want. And then patient selection is always a factor. Beware of the female of the species, dangerous. Requirements for successful multifocal IOLs, everything must be perfect. Biometry, cornea, posterior capsule, vitreous, macular retina surgery, everything. And then you have a good multifocal IOL, because there are no perfect multifocal IOLs. That doesn't exist. Thank you very much for your attention.
Thank you, Dr. Johan. Though let me tell you, I didn't really like the implication that's coming out of his talk. I think it appears like a relationship between a husband and a wife, where the husband feels that he is delivered to the utmost, but the wife doesn't really feel so.
I told her these figures first, and she said she knew that.
So, based on your experience, would you stop doing this multifocal IOLs in presbyopic patients, or would you proceed? And if you will proceed, what will be different from what you have done before?
Well, I will definitely proceed, because there are patients who are extremely happy and they tolerate the side effects. I just have to pointed out that there are side effects. And the number of people, I think, differ from country to country. I think it depends on the attitude of the people in the country. If you are very uptight, perfectionistic, you want everything right, you will be less inclined to be happy with this lens. If you are more relaxed, I just don't want to wear glasses, I want to enjoy life, and I want to see, then this lens works very well. For myself, I'm perfectionistic, I will not take the lens. But there are friends of mine, colleagues, ophthalmologists, who will take the lens. So it's a difference in factor. But I think one should use it if you have the right patient. The other thing is, your question is about the results, improve the results. Astigmatism is a factor. One must get rid of all astigmatism. That's absolutely crucial. And that's another talk in its own right. But patient selection for astigmatism is very important, because if you start with 1.25 diopter at an oblique angle, you're looking for trouble. And then on the other hand, I had one patient where he was -3 astigmatism, and he was working somewhere in Arabia. And he said, I cannot wear glasses. And I said, okay, we'll do limbal relaxing incisions plus the lens, and then we'll LASIK you later. And he said, okay, let's do it. And we got him to plano, and he was happy. And we never did the LASIK. And he's still happy. He's a karate black belt, and he's one of these active people. And so I think the lens is a good thing. We must just have good patient selection.
Did you do the same experience between multifocal lenses versus monovision with your own system? Because it will be very interesting to see the expectation and everything on a simple manner.
The problem with monovision in South Africa, I don't know whether I don't explain it well or whether my patients don't understand me well, but I don't seem to get many people who want it. And then I talk them into a contact lens trial, and they really don't like it. So I don't do a lot of monovision. Some patients end up with monovision, and then it takes a lot of talking to get them to accept it. So I think it's personality trait maybe of the doctor or of the people or a combination. So no, I don't have the figures.
I have a question. What did you do for those unhappy patients, and how long do you wait before you do anything definitive?
Well, what's interesting about these people, especially the ladies, some of them they see me a lot, and I say, okay, neuroadaptation, I explain the process to them about 2 images available all the time and so on. And then they say, I don't like it. And I say, okay, well, shall we take out the lenses? Sometimes I use shock therapy. I say, no, I don't want you to take out the lenses. I say, do you wear glasses? No, I don't wear glasses. So what are you going to do? Then I give the ball to the patient. And the patient will say, I'll wait a bit. I'll come back. Then they come back after 6 weeks and we test the vision. They got 1.0 for all distances. And I'll ask them now, are you happy? No, I'm not happy. So what do you think we should do? Nothing. So they are sort of happy. They are functional. They can do everything they want to do, but they still see the ghost images, they still see the starburst, they still see the halo, and they don't like it. But the advantages of the lens are more than the downside of the lens, and that's why it works, and that's why it's continuing to work.
Yeah, typically, how long does it take for neural adaptation to happen?
In my experience, anything from 1 day to 6 months. If it hasn't happened after 6 months, it's not going to happen. But I've seen people who come in at 5 months and they still complain, and I say, I'll see you next month, and after 6 months, I'm happy. So that happens.
I don't know why, but the monovision, in some country, people are happy with monovision, for example in USA. In my country, the people don't like the monovision. With laser and with intraocular lens. In this moment, about the realistic expectation of our patients, I think that we need to speak about bifocal, multifocal, bifocal intraocular lens, trifocal intraocular lens, because with, for me, the rector is my first option in this moment. Maybe no in the future, because it's not a multifocal intraocular lens. It's very common to have many people not happy for this. We speak about multifocal and rector techniques and other intraocular lenses are not multifocal intraocular lenses. I think in this moment, with 2 or 3 different trifocal lenses in the map, we can speak about bifocal intraocular lenses.
You're absolutely right. It's bifocal.
Are there any questions from the audience?
Can I just ask a quick question? Johan, the N+ that you used was the 1.5 ad or the 3 ad, and are the symptoms, the night glare and so on, symptoms different between your Restore and your N+ patients?
Yeah, good question. It was the 3 ad, and the Restore study was the night glare and halos were more than with the M+. But the M+ reported 2 or 4 lines actually going down in an inverted V shape. If you put the lens in vertically, the 2 lines go to both sides inverted V, and they see them every night, always.
Thank you.
Thank you.
I would request Dr. Mark to please